So moved.
Second. Any changes, deletions, additions? Hearing none. All those in favor?
Aye.
Opposed? Motion carries. This morning we met in an executive session, and I know David will give us an update on the results of that session. So I will turn it over to David.
Good morning. Good morning, commissioners. Thank you all for being here early this morning. So we met, the board met this morning in executive session to consider the performance of select entities that were referred to the commission by CHIA based on their 2015 to 2016 spending growth. And so at the beginning, we're just going to briefly walk through the results of that conversation and this cycle of review and an update on our PIPS process. So I'm going to turn it over to Kara Vidal, who's going to walk through a few slides summarizing the work that we've done this year.
Thank you very much. Good morning.
Good morning.
So as mentioned, the board did meet this morning and did vote to conclude review for the entities that had been referred based on their 2015 to 2016 spending growth. And the board voted not to require a PIP from any of the referred entities. So that process is complete. We'll tell you a little bit about some of the key themes that we saw in a slide or two. But in the meantime, no rest for Ramsey Hoge, who is our primary analyst on the PIPS process, because we have received the next list from CHIA based on 2016 to 2017 performance and anticipate diving into that immediately. I think this is the earliest that we've ever received the list from CHIA, so thank you very much to our partners. We appreciate that, and hope that by diving right into our analytics, we should have some early results to share with commissioners in January and may even be ready to identify some entities for follow-up in February. This year's review, which was the fourth since this provision of Chapter 224 went into effect, was the most intensive review cycle we've had to date. Right from the outset, it was the highest number of referred entities that we have had since CHIA updated their methodology to refer only on final data. It was also the highest number of referred contracts and books of business that we've had. In their April executive session, the board directed us to follow up with the highest number of entities that they have in the past, and in July, directed us to conduct further, more rigorous review of more entities than they have in the past as well. Overall, there were 3 executive sessions of the board, 13 meetings at least, not counting phone calls and smaller communications with entities, and we issued over 10 requests for written information as well. So definitely put both Ramsey and Massachusetts payers and providers through their paces this year, and I think learned a great deal in the process. A few themes that came out of this year's cycle to share with you. The first will sound familiar. We raised this, I believe, last November as well at a presentation to the MOAT committee, which is that we continue to see unadjusted growth rising more quickly than health status adjusted growth. And that is driven by increasing risk scores. And as we've said in the past, we continue to feel that health status adjusted TME is a very important metric. We really do not want to penalize those payers and providers who are caring for the most vulnerable populations. That being said, unadjusted TME represents real dollars, and the benchmark is measured in unadjusted TME. So we do think it's very important to track both of those trends. We also did not see as much in our data, but heard much more in our follow-up conversations about the impact of patient churn on performance. We certainly saw this in the MMCO space, where there continue to be changes based both on shifts in patient eligibility for new products, as well as instability at the connector. But we saw it in the commercial space as well, and it was raised to us in a few cases that the numbers that we have are net change in member months in a given contract. but we don't see both the influx of new patients and the departure of patients from either a payer's book of business or a provider-specific contract. So there could have been quite a bit of increase, quite a bit of decrease, and we might not see a big change. And that's important for year-over-year comparisons to make sure that the population we're looking at is as stable as possible. And then finally, it was raised by several payers and providers that they face challenges in addressing some of the causes of their growth. Especially noteworthy were pharmacy spending. Hep C medications were still impactful in this time period. Leakage to high-priced providers is quite impactful on TME and can be difficult to control. And high-cost outlier cases, we also saw some credible data on the impact that just a few very expensive patients can have on trend. And finally, after each PIP cycle, internally we like to do a little post-mortem and find ways for the team to be more efficient or accurate or effective. This year, because we've now gone through 4 cycles, we wanted to do that for the process as a whole rather than just how we've implemented it. And I think found that there are some strengths and some limitations worth discussing at this meeting. So on the strength side, it really is helpful to have a process to hold individual entities accountable. Obviously, the Commonwealth as a whole is held accountable through the benchmark process, but we know that even if the state as a whole meets the benchmark, it is not always the case that individual payers or providers are sort of pulling their equal weight or insurance categories as a whole are pulling their weight in making sure that the state hits that target. So it is very helpful to look individually rather than just at a statewide level. We also think that this oversight has a sentinel effect that encourages entities to limit their spending growth even in the absence of a performance improvement plan. I think knowing that there is an agency that is looking at your individual contract level performance has been meaningful for payers and providers. We have learned quite a bit through this process about the strategies and operations and resources that payers and providers are using to control their cost growth. That's been informative not only for performance improvement plan work, but across the agency. And even when a PIP is not required, we think there's some potential for meaningful conversations and discussion with referred entities and the possibility for them to make certain cost containment commitments in the absence of a PIP. That being said, there are also some limitations that are meaningful as well. And a lot of them are based on the statutory referral standard that CHIA must use, which is based on growth in health status adjusted TME. And there are three words in that statement, all of which are somewhat limiting. Growth, health status adjusted, and TME. So if we take each of them individually, starting with TME, TME is a measure of spending for a defined patient population. So it has been used by CHIA to measure spending for a payer's book of business or for a provider's primary care panel. What we don't have is an ability to apply a metric like that to other provider types that have a meaningful impact on spend but do not have a defined attributed patient population like hospitals or drug manufacturers, for example. So there are some entities that we do not examine through this process. The second is growth. So there is an ability that we have always recognized in this process and try to be very cognizant of our reviews for an entity with very high baseline levels of spending to grow in a moderate fashion and stay below the benchmark and still have a much greater impact on total spending than an entity with lower baseline levels of spending that grows much more rapidly. So we are cognizant to the extent we can be in our review of that impact, but cognizant of that impact in our review, but sometimes entities are not referred to us at all because their growth may be below the target. And then finally, health status adjustment, as previously discussed. We do see that unadjusted trends and health status adjusted trends are not always moving in parallel. We have asked many entities through this process about their growth and risk scores and asked for an explanation. I wouldn't say this was a universal answer, but we often hear that it is a result of efforts to do more complete documentation and coding, which we think is probably positive, and having complete documentation is probably good for patient care, but we then question why the unadjusted trends are sort of rising in parallel. And then finally, under the current process, the HPC cannot require that a PIP includes specific goals or strategies. And while we do think that the payers and providers are most familiar with their own data and priorities and trends in patient population, we think it would strengthen the position and the impact of a PIP to be able to negotiate some of those key provisions with the entity, which we're unable to do now.
Thank you. Kara, thank you, and thank you for your work and the staff work on the detailed analysis that went into examining the 4 organizations that we did further analysis on. I think that while we voted to end the 2015-16 PIP process, I think I speak for my fellow commissioners, we did so with a lot of concern about continued cost growth that we're seeing in various contracts from both payers and providers. And so as we begin the new process, continued vigilance in looking at that as we go forward. And I'll ask Professor Cutler, who chairs the market oversight, to comment as well.
Yeah, thank you, Mr. Chairman. First, let me echo the thanks to Kara and the staff at CHIA and so on. It's ironic because this doesn't happen in the public, so people don't know how much work goes into this. And it's just an extraordinary amount of work that goes into this. And so thank you for handling it the way you do. Just a few observations I think that we've had in committee and that I've had in a few years of being involved in the process. One is that I think this particular process, amongst all the things at the HPC that we do, this particular process has been the most challenging relative to what I would have guessed of everything that we do. Both the data challenges and the operational challenges and so on. It's just kind of like it involves more stuff than I guessed relative to other things, and so that's I think just a statement, but it sort of it reflects stuff. I would say there are probably a few areas that as a commission we need to think about, and I think Kara listed some of them, and I'll just sort of give my summary of them. One is this issue about what is true change in risk and what is coding. And we've had that discussion in the MOAT committee, and I think we have to try and push it to some kind of resolution so we can say, what are we going to do about it? Because it's really hampering our ability to do very good analysis and very good assessments during the PIP process. Second, and Kara also mentioned this, is the data lag, which is really quite acute. And I know it's something that Ray has worked with his team to speed up so that this year we have it earlier. And I think we want to have even a further series of conversations about whether we can speed it up even further so that we can be reflecting the time frame over which we're doing the annual cost trends benchmark rather than the lags, which just make it very difficult. And then third is, I think we may need some legislative changes associated with some of the issues around referral or what we look at, that again, because it's been more involved than we had thought, we've learned things about how we could make the process go smoother or what kinds of things it would help the Commonwealth to be able to access. And with the governor's proposal for healthcare reform in the legislature, interested in that, I think we should be able to submit to them some recommendations about what the legislature and through legislation we can do to make this process be as effective as it can be.
Thank you.
Any other comments?
Comments? Others want to add? Okay.
Great, thank you. We're going to move on in the agenda to our standard business of notices of material change. and Kate Scarborough Mills will handle this piece of the agenda.
Great. So just to give you our standard update, since 2013, when we began this process, the Health Policy Commission has received notice of 107 provider transactions, with physician affiliations and clinical affiliations the most frequent, followed closely by hospital affiliations. We currently have 3 notices under review. The proposed acquisition of Exeter Health Resources, a health system in southern New Hampshire, by Partners Healthcare. The proposed joint venture between Bay State Medical Center and Greater Springfield Surgery Center, an ambulatory surgery center located in Springfield, under which Bay State would acquire 51%. And the proposed merger between 2 federally qualified health centers, East Boston Neighborhood Health Center and South End Community Health Center. Since our last board meeting, we also elected not to proceed to a CMIR for 1 transaction, the proposed partnership between Bay State Medical Center and AmSurge Holdings. AmSurge has an ownership interests in ambulatory surgery centers throughout the country, including 9 in Massachusetts. But under this transaction, the parties would form an LLC with Bay State as the 51% owner, which would then acquire AmSurge's 61% interest in the Pioneer Valley Surgery Center, an ASC in Springfield. So 51% of 61%. I'll pause there in case there are any questions.
Questions? Thanks, Kate.
Great. Thank you. So for the next agenda item, we wanted to come back to a conversation that happened at the cost trends hearings this year around administrative expenses, particularly for health plans. And there was, after the cost trends presentation from Chia and some of the conversation, there were some continued questions around how the state is measuring and calculating administrative expenses in this area, and how the Chia report may differ from calculations around medical loss ratio, which is a calculation that is perhaps more well known in the market, and that there are state and federal standards around medical loss ratio. So we thought it would be helpful and important to just spend a few minutes here today just to come back to this issue, to kind of clarify the differences between these different methodologies. Happy to engage with commissioners on further questions, but Ray was very helpfully willing to come back to talk about this particular issue, and also want to acknowledge our colleagues at the Division of Insurance who also helped prepare this particular part of the presentation. So with that, Ray, I'll turn it over to you.
Thank you very much, David. Good morning, commissioners. It's a pleasure to be here. As you know, one of Chia's key roles is to create the factual foundation that supports better healthcare discussions and decision-making in the Commonwealth. And so the last thing we want is any confusion to ensue from a result of any of the work that we've done. And at the annual report, in Chia's annual report, and in our presentation at the cost trend hearings, we reported on administrative expenses of health plans. And as David said, that's not exactly the same as the medical loss ratio. Created some confusion, and so we've got a few slides that hopefully will clarify what we were talking about, how that differs from MLR. And then offline, we've got a year between now and the next report. I think we need to think about, why are we reporting different things? Should we slow down and report the same thing, or how can we sync up, or is there independent value to the 2 different measures, and we just need to contextualize them a bit better? So next year we'll do a better job for sure, but in terms of this year, this first slide calls out a couple of key bullet points. As I said, Chia's annual report and our presentation at the cost trend hearings had several slides. It was about fully insured health plans and their administrative expenses and their surpluses in the merged market and for larger employer groups with more than 50 employees. It's important to understand that what Chia does is we provide a 1-year snapshot. So it's not a 3-year, as you'll learn that MLR is. So it's 1 year, and it's all payer. We're not looking at the performance of individual health plans. It was a market-wide snapshot. So that's what we report on. It's a useful metric, we think, in certain ways, but it shouldn't be confused with measuring individual plans' performance on medical loss ratio. So the next bullet point calls out a bit of the detail about the MLR. Both federal law and also in Massachusetts state law, which is stricter, requires health plans to spend a certain percentage of their premium revenue on clinical services and also on quality improvement activities. The next slide will show you a little more detail on what's included in the numerator and denominator. And this percentage is known as the medical loss ratio. There's a standard federal template that's used to calculate it. And it's used, as I said, a 3-year average of premiums, claims, and expenses. And if an insurer or a carrier's calculation falls below the statutory minimum, they're required to provide rebates to the covered individuals and groups for that year. And as you'll see, it's coming up on a slide, there is a history in this market. We measure this, monitor it, and individual carriers are required periodically to issue rebates. So the next slide. Thank you, David. All right, so this just graphically shows the difference between the measure that CHIA reported on and the medical loss ratio. So the CHIA measure is a more gross or higher level measure. It's simply claim spending over earned premium. So it doesn't have a lot of adjustments. In fact, it has no adjustments. It's really just those two numbers, numerator and denominator, and you get, and we'll see some of the figures that we came up with using this approach. Medical loss ratio, as you can see, is a more sophisticated concept because you certainly want to give healthcare carriers incentive to spend money, for instance, on quality improvement programs, and so you add that to their claim spending so they're not penalized. And similarly, money that they spend on taxes and fees is not actually, you need to credit them for premiums net of taxes because that's not really revenue that they have. So the medical loss ratio is a more sophisticated look at this, and it's a statutory measure, whereas CHIA's is just a metric that we've created in the past. Anyway, so this slide calls out the differences between the two, and as I said earlier, ours is an all-payer 1-year view, whereas MLR is a 3-year look at a payer-specific view of things. All right. I will not try to summarize this slide. Just for your records or as a takeaway, you can see this is from DOI. This is the actual federal calculation template. This is the methodology that's used to calculate MLR. So you see all the different credits and offsets and so on. This is a roll-up of actual data for Massachusetts statewide. As I said, it's done on a carrier-by-carrier basis, but this is a statewide roll-up. And it shows you all the different factors that go into calculating the actual MLR. And then the next slide, just a few final points. As I said, the reason for the 3-year window is to account for actuarial volatility, and I can't speak to this as well as many others, but this next bullet point points out there has been volatility in the market. There's been a lot of activity, as we know, at the federal level, a lot of federal programs coming online, going offline. And as a result, and the carriers have to make predictions about, a bunch of things, prices, utilization, membership, and so on. And so the experience in 2017 and 18 is more stable than had been in 2016. But in any event, the next bullet point points out at least one health plan each year from 2016 to 2018 has had to issue MLR rebates. So with volatility or not, individual carriers are held accountable for meeting the medical loss ratios, which is 85% or 88% for the merged market, 85% for all others. And just for the record, which I think most people here know, the national rule is 80% for merged market, and so we are substantially more strict about administrative costs in the merged market in Massachusetts. And then the final bullet point just points out that when you have rebates, that too should credit off of the income, because that's income that they receive, but then ends up being credited back to members or groups. So the final slide, what you'll see is at the top is the CHIA reported administrative expense ratio, which we now know is kind of a very high level number. And I think part of the confusion was people see this and they thought, oh, does this mean that the state is sliding sort of out of compliance with the medical loss ratios? Or perhaps people thought that. No, for a couple of reasons. Number one, as we've learned, our number is not, there's a bunch of adjustments you perform to get to medical loss ratio. Our number was a 1-year number, not a 3-year number, and there has been volatility. And then lastly, because ours is all payer, I think if you took out one payer who did have to issue rebates in 2018, the number would actually flip up to being over the 88%. So because it's all payer, it hides things that are happening underneath that cover. So anyway, this slide, top and bottom, shows you the difference between the gross numbers as reported by CHIA, and then the bottom is a DOI calculation on the merged market, where you see the actual components, and you see that although as I said, MLR is a 3-year number, these are actually 1-year views from DOI. But you see that even in the year 2018, the market-wide hit the 88% threshold. Hopefully that clarified things and didn't introduce any confusion, but happy to take any questions that people have.
Very helpful, Ray. Thank you. Questions for Ray? Thank you.
Right. Thanks.
Thank you, Ray.
So before we move on, there was one other statement that was made, and I know you received a letter clarifying around from Blue Cross Blue Shield that I think we should just clarify for people. I actually have it.
Okay.
So, because it was I asked the question. So I asked the question at the cost trend hearings to the panel, which included Blue Cross Blue Shield, as to whether they included social workers as part of their behavioral health network. And Mr. Lynch just incorrectly, the good news is I can correct the record. He incorrectly indicated that LICSW's, licensed independent social workers, were not part of the Blue Cross Blue Shield network, and sent a letter, actually asked for us to clarify that day, and we didn't. In fact, Blue Cross Blue Shield has sent a letter to Health Policy Commission clarifying that since 2008, Blue Cross Blue Shield has included within their behavioral health network, I think it's a 4,800 LICSWs as part of the network, and I think it's just important just to correct the record, and I'm happy to report that Mr. Lynch was wrong.
Thank you, Madam Secretary, and apologize.
No apologies.
Yeah, but good to have that on the record.
Yeah.
So we're going to move on to our next agenda item for the next bit of the meeting here. This is an important conversation around some new authority to the Health Policy Commission that was passed into law as part of the state budget process. As you'll hear, this new authority around the potential review of certain referred or identified drugs is a new process for the HPC, but it is very consistent and aligns well with some of the other review and oversight processes that have long been part of the HPC statute. So today, what we plan to do is walk through a proposed draft regulation and the different component pieces of this regulation that will implement and kind of fill out areas that, that were part of the enabling statute. While a lot of work has gone into creating this draft regulation for today's conversation, I would note at the outset, this is still a first step. And so the vote and the question to the board today is to release this draft for public comment and for public hearing, because we really do believe that it is really important to get that type of feedback and input, not only from the manufacturers, but from all other stakeholders that have an interest in this area. So hope to walk through our thinking with the draft regulation, but also recognize that, again, there will be a collaborative process moving forward for further input, and expect to hopefully be back to this board in early 2020 with perhaps a final regulation. So with that as just a brief introduction, I'm going to turn it over to Lois Johnson, our General Counsel, to walk through both the law and the process and the draft regulation.
Great. Thank you, David. Good morning, Commissioners. And as David mentioned, we're here to walk through the proposed regulation for your consideration to advance today for a public comment period. As always, it's important to anchor ourselves in the statute. And as David mentioned, our new authority was enacted as part of this year's state budget. The budget included two distinct related processes, one for the Executive Office of Human Services, which manages the Mass Health Program, and one for the Health Policy Commission. And on the next few slides, I'm going to walk through those statutory processes. So under the new law, and I'm using Mass Health as a shorthand for the Executive Office, Mass Health can now negotiate directly with drug manufacturers for supplemental rebates. And those are, in addition to those already mandated by federal law. If those negotiations are unsuccessful, then for certain high-cost drugs, Mass Health may identify a proposed value of the drug and gather data and information and potentially hold a public hearing. And the statute does define what high cost means, and it's either a cost per utilizer to Mass Health of $25,000 or more, and that's post-rebate, or an annual post-rebate aggregate cost to Mass Health of $10 million. So based on the information received and comments received through that process, Mass Health may update its proposed value as necessary, and then solicit further negotiations with the manufacturer. If those subsequent negotiations still do not result in a supplemental rebate agreement, the Mass Health program may refer the manufacturer to the HPC for review. So that is how our processes dovetail with that of Mass Health. On this slide, this shows the HPC process, and again, this is triggered only by referral from Mass Health. If a manufacturer is referred to the HPC, HPC is then authorized to collect information related to the manufacturer's pricing of the drug. Then, based on submissions from the manufacturer and other information gathered, the HPC may identify a proposed value of the drug, a proposed supplemental rebate, and may ultimately determine whether the pricing of the drug is unreasonable or excessive in relation to that proposed value. And the law spells out a two-step process for making that final determination, which you can see on the right hand of the slide. That process involves a determination that the pricing is potentially unreasonable or excessive. That triggers additional review of information from the manufacturer as well as other stakeholders, and then a final determination on whether or not the pricing is unreasonable or excessive in relation to the proposed value. So that is the statutory, two of the statutory processes that we're building out here in the proposed regulation. The regulation hews very closely to the statutory process, but does fill out necessary details in order to provide procedural touch points with the board and detail how information is gathered by the HPC. And before I outline the key provisions in the proposed regulation, just want to take a minute to talk about some of the principles used in getting us to this point of the development of the regulation. First, of course, alignment with Mass Health, given the related nature of the authority that Mass Health and HPC has here to review drug pricing. HPC staff worked very closely with the staff of the Executive Office and Mass Health program to coordinate and ensure that the regulatory framework is consistent for manufacturers and stakeholders. Second, this is very much informed by new research of the HPC. This is a new area, and so staff conducted research in particular on processes and efforts of other states, both to review drug pricing as well as state drug price transparency laws, in particular New York and Oregon and Texas. Staff also researched processes used in other countries to determine value of pharmaceutical products. And so the proposed regulation really draws on that research. Finally, as David mentioned, the regulation really mirrors similar HPC market oversight regulations. We follow, where applicable, the procedures used in our MCN CMIR process, that of the registration of provider organizations, and in some instances, the performance improvement plan process, where the HPC has existing processes, in particular, an experience in reviewing confidential information from market participants and providing that oversight of market conduct. So that said, with those principles, we certainly look forward to feedback and comments of the board members today, as well as stakeholders moving forward. So just walking through some of the key provisions of the regulation. As I mentioned, the review process only applies when there's a referral from Mass Health, and it only applies to those manufacturers and drugs that are covered by Mass Health or anticipated to be covered by Mass Health, There are drugs for which, and manufacturers for which negotiations have failed, and those are only high-cost drugs. Again, that threshold of $25,000 per utilizer or $10 million in the aggregate to Mass Health. The regulation specifies the information that the HPC will give to the referred manufacturers with a notice, and also specifies the information the manufacturers must submit to the HPC for review. The regulation provides sort of 4 things that must be, or must be and may be submitted to the HPC. First, the manufacturer's analysis of the drug's value. Second, a completed standard reporting form, and this is required in the statute, and I'll detail that a little bit more on the next slide. Third, any specific information to that manufacturer that's requested by HPC. And finally, any data that the manufacturer elects to submit and considers pertinent to the review. So in terms of timing here, the statute requires that information be submitted to the HPC within a reasonable period of time. So the regulation here posits a 30-day time period, but allows for a mutual agreement of an extension of time. In addition, based on statutory language, the regulation requires that the referred manufacturer must attest that the information is true and correct, and that's in connection with compliance, as we'll talk about later. The law allows the HPC to issue fines for failing to cooperate in this process. So the standard reporting form that I mentioned is detailed on this slide. The law specifies some of the elements that must be in the standard reporting form, but gives discretion to HPC to add additional elements that it considers important to the review. The required elements are information about the wholesale acquisition cost increases of the drug, factors contributing to such increases, as well as aggregate research and development expenditures. So the proposed regulation includes other elements considered necessary for the review, including information about clinical effectiveness of the drug, information about utilization of the drug, prices paid by other payers in other countries, and other financial information. And here, many of these additional elements are drawn from other state statutes, in particular the New York statute, which has a lot of elements around financial expenditures of manufacturers. And we also drew from other transparency laws, as I mentioned, California, Oregon, and Texas. Because the statute directs the HPC to develop the form with input from manufacturers, the HPC plans to release a draft of that standard reporting form today, along with the proposed regulation, to give ample time for manufacturers and other stakeholders to provide input. Just a note that the form itself is not going to be part of the regulation. The idea is that that's going to be able to be modified over time with input from manufacturers, very similar to the data submission manual that the HPC uses for its RPO program. So as I mentioned, the statute contemplates the HPC identifying a proposed value for a drug. And in doing so, the regulation states that the regulation provides that HPC will consider the drug's benefits to the Commonwealth and its residents, and consider a range of factors that are listed on this slide. And those factors are drawn directly from the statute that governs Mass Health's process here. So things like clinical efficacy of the drug, utilization of the drug, whether or not there are pharmaceutical equivalents, the potential for the drug reducing the need for other medical care, analyses by third parties, and the pricing of the drug and prices paid in other countries. So the regulation does not define what value is, nor is it prescriptive about exactly which factors must be used, but instead allows for a consideration of multiple factors and a holistic review process applied for each drug that comes before the HPC. In addition, following the statutory language, the regulation does provide that the HPC may identify a proposed supplemental rebate for the drug in consultation with Mass Health. And as dictated by the statute, the HPC must take into consideration any supplemental rebate agreement that came up in negotiations with Mass Health, and may base that proposed supplemental rebate on the HPC's proposed value of the drug. As I mentioned earlier, there's a two-step process or two-stage process that is contemplated in the statute, and the regulation details that process. So first, the regulation provides that the HPC shall make a determination to close review of the manufacturer, very similar to our PIPS process that we just discussed, or by vote of the board, determine that the manufacturer's pricing is potentially unreasonable or excessive, and that vote would trigger a further review process. That further review process involves providing advance notice to the manufacturer and requests for additional information, including the manufacturer's justification for its pricing, as well as sharing with the manufacturer the information used to identify the HPC's proposed value of the drug. The manufacturer will then have 30 days to respond to those additional information requests, but again, the regulation provides for an extension of time by agreement. In addition, the HPC shall also request information from other interested stakeholders, including patients, providers, and payers. The regulation also provides that the HPC may at this point hold a public hearing. So the next step is the HPC may then, within 60 days of receiving completed responses from the manufacturer, and by vote of the board, issue a determination on whether the manufacturer's pricing of the drug is unreasonable or excessive in relation to the HPC's proposed value of the drug. So the regulation provides that the determination made will be posted on the HPC's website, so it will be made public. Very similar to the PIP regulation. And like the report that concludes the cost and market impact review process, this would conclude the process of HPC review here. A couple of other provisions to note. The regulation does contemplate and allow for further supplemental rebate negotiations between the manufacturer and Mass Health at any time during this process. And upon a receipt of a written request by Mass Health to withdraw its referral, the HPC may close review. And an important provision that I mentioned earlier, the information received by the HPC from manufacturers, recognizing that it's highly sensitive information, is expressly exempt from the public records law, and the HPC must keep it confidential. And that this is a similar confidential treatment to the information gathered both in the PIPS process and the cost and market impact review process. The regulation does clarify that the HPC may disclose a narrative description provided by the manufacturer, which is designed to be suitable for public release regarding changes in wholesale acquisition costs and prices net of rebates over a 5-year period. In addition, the HPC may produce reports that summarize its findings, consistent with its responsibilities under the law, but we cannot disclose specific prices or rebate amounts. And finally, as I mentioned, to ensure compliance, the statutory scheme allows the HPC to assess penalties of up to $500,000 per instance if the manufacturer fails to timely provide information to the HPC or knowingly obstructs the HPC's ability to reach its determination. Again, just like in the PIPS process, the penalty will only be assessed after a hearing process and by vote of the board. So that walks through the key provisions, and I'm happy to answer any questions.
Thank you, Lois. There's a lot here.
Oh, thank you. If we go back to 29 for a moment, Lois, where we talk about the wholesale acquisition costs and prices, does that include, or is it intended to include the cost of public funding, for example, the raw research on the basic sciences, or funding for work that was actually done directly by the federal government or contracted by the government? Does this allow that or require that?
Actually, yes, although it's not specifically mentioned on this slide, you will see in the proposed or the draft standard reporting form, we do intend to collect that information.
Okay, thank you.
Other questions for Lois? Rick?
I have a question, Lois, although maybe for Secretary Sutters. So if at the end of this long process, the board continues to vote that the pricing is unreasonable or excessive, what does that mean for Mass Health? Do you not cover this particular drug, or do you? How?
So Mass Health is actually required to include all drugs on its formularies. What I would say it does is, so first of all, let me just thank HPC for extraordinarily close work with the Mass Health team to really line these up. And there's another slide that you'll see in terms of how we're rolling out the regulations and the public process together. So one, the direct negotiations that the budget gave Mass Health, we're already engaged in those negotiations. And these processes are only when we feel like we have not been able to achieve a satisfactory negotiation on behalf of the citizens of the Commonwealth that we would refer to HPC. We believe that it gives sort of another opportunity with more confidential information for HPC to do a deeper dive than what we were able to do in our two-part process. So this is really a third process. So we have one, direct negotiations. Second, then we can propose a public process to establish a value. And third, if that's then not successful, Rick, then we can refer to HPC. We're hoping that that scaffolding process actually serves the purpose, which is fair value for the Mass Health program and the citizens of the Commonwealth. If HPC, and we haven't gotten that far, if HPC, we believe that the information that HPC will gather will be helpful then for us to sort of go back and start the process again, honestly. And we're hoping, and let me just give you so the budget passed the end of July. We're working very quickly. So we've already concluded negotiations with 3 drug manufacturers for 6 drugs, 70 plus million gross, 7 million net savings. That's just coming out of the box. We have another 30 drugs we're actively negotiating with. So
Okay.
Does that help a little bit?
Yeah, no, that's helpful. It sounds like it's the process is what you hope will
Yes.
provide you with the prices that are reasonable. Yeah. Okay. Thanks.
I do very much appreciate the hard work of the legislature, the House and the Senate during the conference process of coming up with this tool for the Mass Health program and working closely under the structure that was created of 224 on this. So,
Lois, I'm wondering if you could just clarify when the information becomes public. Does it become public at a notice of potentially unreasonable, or is it after the fact and there's a public hearing in there? So I assume that means it's public.
Yeah, actually, neither the statute nor the regulation really speaks to whether just the name of the manufacturer, whether the referral from Mass Health or any of the stages in the process is confidential. So it would not be.
Okay.
what is clearly confidential is any information
Underlying
submitted.
data.
Yes.
Yeah. Okay. Thank you. Other questions? Want to go over the proposed timeline?
Sure.
Great. So as you can see, this is our regulatory development timeline. We're here to advance the proposed regulation for public comment. We anticipate that hearing to be on December 13th. The close of the public comment period will be on the 20th, and then we expect to be back before this board, after processing comments with a final regulation for your vote on February 5th.
And that aligns with Mass Health.
Right, so the Mass Health regs will be posted on our website this Friday, the 22nd. So we're close.
Great, and the HPC's proposed regulation will be posted on our website following the board vote. And here, just as the Secretary mentioned, we are coordinating with Mass Health on the scheduling of the public hearing for our respective regulations on Friday, December 13th. I would be here in the HPC offices. The hearing on the Mass Health regulation, the executive office's regulation, would be in the morning, and the HPC regulation hearing would be in the afternoon starting at 1.
Any further questions? So there is a motion in your packet to move forward with the issuance of the proposed regulations, which I know all commissioners have seen. Do I have a motion to proceed?
So moved.
Second.
Second. Any further discussion? All those in favor?
Aye.
Opposed? Motion carries. Great.
Thank you very much.
Thank you.
We are looking for commissioners to be present at the December 13th hearing. So if you can put that in your calendar, we would appreciate it.
A coincidence that it's Friday the 13th. Thank you, commissioners. We have 2 more agenda items for our board meeting this morning. Now I'm going to ask members of the Research and Cost Trends team to join me at the table for our next agenda item, which is going to walk through some findings from our upcoming Cost Trends report. It's that time of year where we start to roll out some of the different analyses and research that we've been working on literally for the entire calendar year, and to get your feedback and input as we begin to craft the final Cost Trends report, which would be issued early in 2020. First, want to just share with you an outline of the annual Cost Trends report. Should feel very similar and consistent with years past, where in the main report we'll have a main chapter with overview of trends in spending, many of the findings that David Auerbach presented at the Cost Trends hearings itself in terms of our performance against the benchmark. And then we have a number of chapters where we do deeper dives, and we really try to pick some dynamics that we want to really drill down further in. And so the 2 areas where we're going to have a much more in-depth part of the Cost Trends report is really around hospital spending writ large in the commercial market, both on the inpatient side and on the outpatient side. And as you'll hear today, the 2 are related and intertwined as we're seeing shifts in care between those 2 settings. We'll have policy recommendations and a dashboard of performance metrics. Additionally, on the right-hand side of the slide, we'll have a number of different chart packs that will look at many of the metrics and factors that we look at every single year. ED utilization, readmission use, post-acute care, as well as we'll have analyses of the performance of different provider organizations, both on spending and on issues like low-value care, as well as the uptake of alternative payment methods. So a lot of these are chapters that maybe have been deep dives in previous years, and we want to continue to update and make sure that we have the best up-to-date information. So for today's presentation, we're really going to focus more on the commercial hospital inpatient trends. And so with that, I'm going to turn it over to Laura, who is our Associate Director on the Research and Cost Trends team, to walk through some really interesting new findings today. And we'll be back before the board, not today, but later to do the outpatient part of this presentation.
Great, thank you, David. Before diving into the research findings and why we're covering this topic, I want to acknowledge Leiden, who's going to be presenting some of the results, and Katya for the work that they've done on this. So today we're talking about our commercial hospital inpatient trends in Massachusetts. And the reason we're doing this is because some of our prior research has highlighted three important trends in this area. One, from last year's cost trends report, is rising prices. Even after holding acuity constant, we see rising prices at 2 to 3% per year. Earlier this year, we presented on rising patient acuity, where again we see a trend of rising patient acuity at 2 to 3% a year. And in that work, we conclude that it's stemming in part from changes in billing and coding practices. We really did a look to see if there were any indications with length of stay or NICU or ICU days to say that, you know, this is a true change in acuity, and we couldn't fully account for that, so that's why we came to that conclusion. And at the same time, we're seeing a decline in inpatient volume. And in both that prior presentation on coding intensity, as well as in the cost trends hearing, we presented this horseshoe graph, which I'm not showing here again today, but where we show you from 2013 to 2018 that there's been an 11% increase in acuity. And at the same time, in that same time period, we see a decrease of in commercial inpatient volume by 14%. One of the conversations we've had in our prior research is this, what is behind this decrease in commercial inpatient volume? Is this just due to switching sites of care? Are we becoming more efficient in care and moving more things to outpatient? So we really wanted to unpack that. But first, to zoom out for a second, why are we focusing on commercial? And here we see that from this time period, 2014 to 2018, Medicare inpatient stays have stayed relatively flat, gained a little. We see actually a big increase in Mass Health inpatient stays. When we go back to our opioid chart pack that we released last spring and just calculate the number of discharges, actually about 37% of that increase is due to opioid-related stays. And then we get to this bottom line here, our commercial, where we see it's has declined almost 10%. And we want to study this because it has implications for the number of inpatient beds that we have in the Commonwealth, as well as understanding which systems are losing these relatively high-paying commercial stays. So we want to understand what's happening here so we can predict whether or not this trend is continuing or if it's going flat. So this slide is the tracker that we'll be using for the rest of the presentation. We're going to be going through these research questions. Specifically, we're going to be talking about, is this volume decreasing across all categories of admissions, or is it specific categories of admissions where we're seeing this decrease? And are we losing these admissions or stays at all hospitals? Going back to our coding intensity conversation, we're going to talk about whether this has an impact on the observed acuity trend. And then we're going to unpack the underlying reasons for the decline. So is the decline the result of changes in population health or the need for inpatient care at all? Or is this due to changes in clinical practice or shifts of care to other sites of care? And then future, because I know we're going to get asked this, is if there are shifts to other site of care, what are the types of patients and what are the implications for spending? So this presentation is going to focus purely on the volume question, and we're going to tackle the spending a little later. So with that, I'm going to hand it over to Leiden.
Thank you, Laura. So to return to that first question again, are these volume decreases occurring across all admission are the volume decreases occurring across all admission categories and hospital types. Here we return back to the orange line that you saw previously on the all-payer view. And we show that the commercial, we break down the commercial decline into 4 different categories. We show both maternity admissions, both admissions from the emergency department, scheduled admissions, and those behavioral health. And we show that here that scheduled and maternity discharges have declined steadily since 2013, with both the admissions from the ED and behavioral health admissions being relatively flat. The scheduled admissions themselves have decreased about 19.4%, of almost 20% there. To dig into that a little bit further, here, the 100% bar at the top decomposes both of those, decomposes that trend amongst those 4 categories. And we can see that maternity and scheduled discharges represent about 90% of the overall decline in inpatient during this time. Here, it's a slightly smaller time trend with 2014 through 2018. And you can see, again, that orange line at the bottom there. We move on to see, not only is this going across all categories, but is this happening at all types of hospitals? The 5 groups of bars here show 2014 and 2018, the total volume of scheduled inpatient discharges happening amongst these 5 hospital types: academic medical centers, community high public payer hospitals, other community hospitals, specialty hospitals, and teaching hospitals. And we can see that the largest decline in volume happened for for community high public payer hospitals at 32%, with, despite the decline across all hospitals, the community high public payer is having the largest impact, the largest experience of decline during that time. This next graphic shows something very similar, but only for maternity discharges. And here, specialty hospitals are not included, as they have they rarely have maternity cases. And here we see, very similar to the previous, that the largest decline for these maternity discharges were for the community high public payer, at about 20% of the decline. So again, the distribution of where this care is happening is changing with community high public payer experiencing the highest decline. And here, to further illustrate that point, this shows the share of all commercial newborn discharges taking place in the community hospitals. Here, with both both hospital types combined, and we can see that drop from 50% to 48% in 2018, with, again, the distribution of births changing, moving away from community hospitals in this period of time. And I'm going to hand it over to Laura to talk about the impact on the observed acuity.
So one of the comments that we had received in the prior coding intensity presentation was around, well, what if it's all just lower acuity stays going into the outpatient setting? And so when we were looking at this volume story by type of admission, we decided to take a look at that. And here we see that maternity admissions are low acuity, and so those admissions leaving would result in a higher acuity. The scheduled admissions are actually very high acuity, and a loss of these admissions on net should reduce the acuity that we're seeing in the remaining admission. And so this is just a high-level overview, but I want to also remind us that when we try to look for markers in the prior coding intensity work around whether or not those discharges that we were losing or that were remaining were increasing in severity, we could not find that indication in the discharge data. So we just wanted to take this opportunity to go back to coding intensity and make a quick comment on the acuity.
We'll return back to the tracker to dig into these other last two questions, which are about the underlying reason for the decline. The first point is whether or not it's related to changes in population health or need for inpatient care. We showed you the decline in maternity on one of the first slides, and here we show that the rate that we observe in case mix mirrors the DPH decline in the birth rate of 4% over the here with the slightly longer time trend from 2011 to 2016, and we see that our rate mirrors that of DPH. We also investigated whether or not this was related to changes in clinical practice, and to return to a topic that we've discussed in previous cost trends reports, both in 2015 and 2017, whether or not it's the result of shifts to other sites of care. We evaluated using both the literature, clinical expertise, as well as looking through our data and trying to identify that same trend that we discussed in 15 and 17, both examples of changes in clinical practice and also what seems to be a change from in setting of care from inpatient to outpatient settings. Here, this is an all-payer view. We actually are able to look at US and Massachusetts data on the share of surgeries that are taking place in inpatient settings. These lines show, and a very similar trend in Massachusetts and the US, that surgeries taking place in inpatient settings is actually decreasing over this time period. Here we're looking from 2018 to 2016. And the trend in Massachusetts largely mirrors that of the US. To the other point, we wanted to illustrate what we thought we see as a shift to these different settings of care by picking a few case studies. Again, using the literature, clinical expertise, as well as what was referred to us through our analysis with large declines. Here, these 11 case study examples represent meaningful clinical care categories named CCS, the Clinical Classification Software. And we can use this to group different cases of surgeries or diagnostics to be able to see what might be happening to those trends in care. Here we look at, here we see that there is a very large decline for hysterectomy, appendectomy, and other hernia repair, among other categories. We focus in on these three here on the next couple of slides to show the largest declines for these case studies. This slide shows both all of our case study procedures and the three selected to show the change in the inpatient share of these cases. And we can see in every example and for all case studies a drop in the share of the care happening in inpatient settings. The overall all case study procedure rate share drops about 2 points. And then we can see in the other examples even larger declines with about 10 points for hysterectomy from 2015 to 2017. To further dig into this trend, we focus here only on hysterectomy to see what is happening at systems. Is there care dropping in the inpatient setting and moving to the outpatient setting? And what is the net effect? The orange bars here at the top show the net change of the number of hysterectomies at these for these systems. And we can see the top 4 systems, Bidco, Partners, UMass Memorial, and South Shore, all have a net increase in the number of hysterectomies taking place despite what might be happening with the decline in inpatient surgeries. We take from this that it is possible that systems are able to either retain this care as they are shifting from inpatient care settings, despite the fact that some hospitals have a net drop in their total amount of hysterectomies during this time. I turn it back forward.
Great, thank you, Leiden. And so those are the results that we're presenting today, where again, we are starting to unpack that, the decline in inpatient, and we're seeing the large part of it, one half of the story is that there's truly a change in population trend. We know that maternal births are going down nationwide, and that trend is also true in Massachusetts, and we see that in the need for maternity admissions or stays. But the other half of that is scheduled, and within scheduled, we are seeing some indications that some of this care is shifting to outpatient as we start to, especially when we start to narrow the pool to, in the case of the last slide, hysterectomies that would be eligible for outpatient care, as in hysterectomies that were not performed as a result of a delivery complication. And so for our outpatient work, we are going to start looking at the cost implications of shifting to outpatient care and why our outpatient spending is growing and where is it growing, and again with that systems lens of who is getting this outpatient spending growth.
Laura Leiden, thank you. Questions for either Laura or Leiden? I just had one question. When these data were presented earlier, I saw a comment about an explanation, maybe observation beds use. Did you see how that factored in here?
So
Which don't result in a discharge then?
Yeah, so we have looked at observation beds a couple of times with different lenses over this time period, and my recollection, but I'll look back to Katya to confirm, is that specifically in the commercial population, the use of observation beds did not change significantly, and it decreased. Okay.
Oh, interesting.
So I think that the question was, are some things that were previously being admissions now in observation stays? We actually found during this time period that that's decreased in the commercial population, which
Right.
is surprising.
That's not the same story for the Medicare population, but
David?
So I thought this was fascinating. There's an interesting aspect which the last chart brings up, which is that it appears as if these different institutions are doing very different shares of inpatient versus outpatient hysterectomies. It might be interesting to just show in a chart what across different types of hospitals, what share are they doing inpatient versus outpatient, and similarly for some of these others. And so it may be that some hospitals are doing much more on an outpatient basis, which is cheaper and probably preferred by the patient in most cases, and others are doing much more on the inpatient side. And I think it would be interesting to see how much that percentage varies, and are there some institutions that are doing much more inpatient consistently versus outpatient, as a way of kind of saying where are our resources being used and can we compare that?
Yeah, so I totally hear your point there, and I think that would be very interesting. This is showing a kind of a change over time, but returning to this slide where we're looking at the share of inpatient and outpatient for these procedures, could we then just do that by the big provider groups and see, is there variation, are these averages masking some variation even underneath it?
Mm-hmm.
And I suspect the answer is probably yes.
And I think it would be, we could then feed that back to the providers and say, well, you're doing 55% inpatient. Did you know there's some hospitals that are doing 40% inpatient? So they found a way for, assuming the patients are the same, they found a way for 15% more to be outpatient. Maybe we should learn a little bit about what's going on there.
And just to keep vibing on that, part of it also may be specific market strategies where certain institutions are really investing in outpatient settings or have invested in ambulatory surgery centers or are establishing those, creating those, and are now using their in-system outpatient facilities to a greater degree. Maybe some systems don't have those availability to them. And so, as it's shown on that other slide, there is an interesting thing here where it does appear that there are shifts among systems and also potentially shifts within it.
And I will add that we specifically looked at system for this as opposed to by hospital type, because by hospital type, we didn't see this same story unfolding, and so that also has implications when we're talking about within the larger system, what kind of resources do you have to shift to the outpatient setting?
And just to piggyback on that suggestion, as you look at outpatient trends, I would encourage you to look at other circumstantial factors. So is outpatient utilization going down in a certain unit because that unit may have closed in a given system, or because down the street another system has opened up a big outpatient or ASC that is taking the volume? Because I think we're seeing a lot of that outpatient expansion that's impacting neighboring facilities.
Exactly.
Great.
I suspect that part of the difference may be measured by the underlying etiology for the hysterectomy. There's lots of different reasons to have a hysterectomy, and the underlying etiology and disease process underlying that has varying degrees of immediacy. So it might be interesting to reflect on what the underlying etiology is.
Mm-hmm.
Any other questions or comments? Thank you both.
Thank you.
Great. Thank you, Laura. Thank you, Leiden. And we'll continue down the rabbit hole, so to speak, and try to learn more as we think about also putting these findings into a policy context and really being able to have some potential policy recommendations in the cost trends report. So for our final presentation today, we're going to return to some evaluation results from our CHART investment program, and would ask for just a moment of indulgence on my behalf just to say a few words, because this may be one of the last times that we'll be speaking to this board about the CHART program as we're finalizing the evaluation report. The report is not yet done, but we're going to present some findings today. We're going to be finalizing the report. We're going to have a lot more materials coming out from the program. But this was a program, this was our first investment program, and for a little bit of history, I actually went back and looked at the presentation the first time that we presented on CHART. And in the statute, of course, the trust fund that supports this activity was called the Distressed Hospital Trust Fund. And this commission recognized right away that that was not in line with what we hoped to accomplish with this program, nor did hospitals like to be called distressed. And so we actually changed the name of the investment program to the Community Hospital Acceleration, Revitalization, and Transformation, or CHART program. And I found the first time that we rolled that out was actually in October of 2013. So it's been over 6 years that we've been on this this CHART journey, so to speak. And at that time, and over 6 years ago, when we were first designing the first phase of the program, we had about 1.5 people essentially on staff that were assigned to running this program. And I think, just as a reflection, this was obviously our first investment program, really targeted at some, frankly, disadvantaged hospitals. These are lower priced, nonprofit community hospitals. That was the eligibility laid out in statute, and that have historically not necessarily had the advantage of financial of higher commercial rates, or in some cases the advantage of systems being able to provide them the type of funding. And so we started this program at a really interesting inflection point for community hospitals and for the value that they provide to the Commonwealth in terms of treating a greater proportion of public payer mix, and treating patients in communities that have no other access to care. I will always recall when we were in the first phase of this program, the North Adams Hospital actually closed, and Commissioner Lord, I think you hail from that area, and it was personal.
I was born there.
You were born there. And so at the same time that we were designing this grant program, we didn't want to just write a check. And we didn't feel that if we just distributed this money and said, here is as free money from the public, that we would not have been doing the public a service, nor the source of this funding, which did come from health plans and certain high-price systems. So we really wanted to try to invest these dollars in sustainable and transformational change. If we just did it so that they could fill their profit margins for 1 year, they would be back in the same situation in the future. And so the design of this program really was about investing in the future, and investing in being able to help these hospitals prepare for value-based payment and how they were going to be able to succeed in value-based payment. Interestingly, and I think most fortuitously, as we'll talk about today, the main chunk of this program, the phase 2, happened between 2015 and 2017. And while we didn't know it at the time when we designed the program in 2015, down the road there was going to be this tremendous opportunity in the Mass Health ACO program. And so in some ways, what this program ended up being is preparing many of these hospitals to be able to participate in the Mass Health ACO program and to prepare them for success in that program. Not all of the hospitals participated in the Mass Health ACO program, but many of them did. And as you'll hear, many of them, the majority of them, the vast majority of them, actually sustained their chart activities and functions in large part because they saw the value and the effectiveness of these programs that we were helping to fund, and that they were now in an environment where they could sustain that through the incentives in the Mass Health ACO program, where they were actually rewarded for being able to do things like reduce hospital utilization and ED visits. I think less fortuitously, I think we expected the commercial market to continue to move towards value-based payment. And unfortunately, we have seen that has been stagnated over the last couple of years, and that we are still predominantly in a fee-for-service based system. And so some of these hospitals were challenged by the fact that these programs, in some cases, are not reimbursed. Some of these services are not reimbursable by commercial payers. And if they invested the money to actually reduce their utilization of the hospital, that actually has a detrimental impact on their financial well-being. So I think one really good positive was the Mass Health ACO program coming online. I think, unfortunately, I think we had hoped that the value-based market would have moved quicker during this time period. So nonetheless, I think we've made incredible progress in, as you'll hear, across a number of different factors. And yes, we definitely wanted to, as a primary goal of many of these programs, was reducing ED utilization or ED revisits and readmissions. But we had a number of other goals, including helping these institutions be able to use data in different ways, having organizational and culture change, integrating behavioral health care, and being able to address social needs and many more. And you'll see that many of these hospitals reported really incredible progress over the 2-year period on a number of these different factors. I do want to note, I think, 2 really important factors that you'll hear come through here, and that I think have always inspired me about this program, was that we made meaningful differences in patients' lives. This program touched tens of thousands of residents in Massachusetts, and I know for a fact, saved lives. and dramatically change the trajectory of other people's lives. So I don't think that we can lose sight of the real patient impact that some of these programs help support. And I also, while not a primary factor in our evaluation, I think another key positive impact has been that we really helped train thousands of new types of clinical staff through this program. A lot of this money went to personnel, but personnel that had not necessarily been a part of the healthcare system before. Community health workers, peer recovery coaches, licensed clinical social workers, pharmacists. These are non-physician staff that we were helping to support and to build teams that now are growing as part of what we think of as the most best integrated way to deliver care. And we were able to help support the hiring of literally thousands of people to do this work, and they've been able to continue this work through the Mass Health ACO program and through other initiatives. And so I know, one of the key reflections has always been hearing from some of the frontline staff, and I know Tim Foley's not here, but I'll channel him in mentioning the frontline staff here who would often report to us that this was the first time in their careers that they were able to deliver medicine in the way that they wanted to, and that the way they had trained for, that put the patient and the patient's needs truly at the center of everything that they were doing. Many of the hospitals, these were, they called themselves the chart team. These were chart people. They had chart badges. And so even creating that identity, and even to this day, the grant money in this phase has long since expired, but many of these people truly still identify with this program. So I do think this program has a really important legacy, both for the Health Policy Commission and for the Commonwealth, and it's something that we've also, I would say, as we've now rolled out other grant programs, we learned a tremendous amount about how to both administer good investment programs, work with institutions, and be able to make evaluation and findings public. So apologize for the longer introduction than usual. But with that, I'm really pleased to introduce again Kelly Hall, our Senior Director for Healthcare Innovation and Transformation, or Transformation Innovation. And Fran Hodgins, who helps run our evaluation team at the Health Policy Commission, to walk through some of our headline results from the program.
Thanks so much, David, and good morning, everyone. Since time is finite, and I think you want to cut to the chase in terms of the findings, let me just add one last thing to David's introduction. And that is, just since this is probably the last time we will talk in any detail or depth about the CHAR program at this forum, I do want to acknowledge the incredible investment of time, energy, resources, and creativity, not only from the staff at the HPC, from our external vendors with whom we've worked, and most importantly, from our awardee hospitals. As David said, it's been a long journey, and there's been an amazing amount of work, an amazing amount of learning that I hope that you'll start seeing reflected in some of our other investment programs. But with that, let me just say a huge thank you and turn it over to Fran.
Thank you, David and Kelly. Great. So I'll breeze through this sort of intro since we've got some great foundation already. But the CHART Phase 2 investment program was a multi-site intervention implemented over 2 years, starting in September 2015. And nearly $60 million was made available to eligible community hospitals across the Commonwealth. And the 4 goals of this program included integrating care across medical, behavioral, and social needs, shifting care from the hospital to the community, building hospitals' capacity to use data and analytics to better serve patients, and ultimately to prepare community hospitals to succeed in a value-based care environment. So today we're going to be talking about the evaluation findings, and so I'll start off by describing the framework that we used to guide our approach. The design of the CHART Phase 2 evaluation borrowed from a framework developed for the evaluation of large CMMI programs, and it considers 3 domains: implementation, impact, and sustainability. We approach these questions using both quantitative and qualitative methods to understand how the hospitals as a cohort performed on all of these questions. Using mixed methods was especially important given the CHART Phase 2 focus on continuous improvement, which meant that the care models evolved throughout the performance period, and so we wanted to capture all of that change and nuance throughout the program. The HPC drew on hospital-reported data and contracted with the Boston University School of Public Health to conduct interviews with chart patients and staff, to administer hospital-wide surveys, and to conduct an analysis of case mix data from CHIA. The evaluation report roughly follows this structure of implementation, impact, and sustainability. So I'm going to start off by sharing some of our findings from implementation to set the stage as we look towards impact and sustainability. After the awards were announced in the fall of 2014, each of the hospitals began a year-long implementation planning period. And during this period, hospitals collected baseline data, which was used to further refine the Chart Phase 2 design and program goals. Chart teams then developed their intervention and care models, identifying partners and investing in technology. As part of their baseline analysis period, hospitals were asked to collect data and analyze it to define target populations. They found that patients with a history of frequent utilization and patients with behavioral health diagnoses represented a significant proportion of the hospital's rates of ED and inpatient utilization. Hospitals also conducted interviews with patients who had frequent acute care utilization, and many patients described how health-related social needs contributed to their hospital use. In response, nearly all hospitals define their target populations either by a history of high utilization or by behavioral health diagnosis, and many hospitals also used social or medical complexity to define their target populations. Recognizing that frequent acute care utilization is a driver of high healthcare costs and can be a marker of unmet care needs, hospitals worked with the HPC to develop utilization reduction targets for their eligible target populations. In the absence of established benchmarks, teams were encouraged to set aggressive targets to catalyze their focus on improving care and reducing unnecessary utilization. And while we think this is a really important and measurable marker of transformation, as David indicated earlier, this is just one of many indicators of transformation that we looked at as part of this evaluation. Completing their baseline analysis, the chart teams moved to their intervention development and developed their care models. While each chart team's care model had unique features, advisement from the HPC and its technical advisor, Collaborative Healthcare Strategies, ensured that teams shared consistent features across the cohort. 6 key features are highlighted here, ranging from high-risk care management to partnerships with local organizations to adoption of new technology. As David mentioned, innovative staffing models were a central component of the chart care model. Interdisciplinary teams typically included clinical and non-clinical patient-facing staff, as well as data analysts. And most clinicians were not physicians, but rather nurses, social workers, behavioral health providers, and pharmacists. And non-clinical roles included community health workers, navigators, peer recovery coaches, and case managers. The focus on these non-clinical roles reflects the Phase 2 emphasis on high-touch care coordination, and chart funding was often important for funding these non-clinical roles, in part because their work has not generally been covered in a fee-for-service reimbursement environment. Chart teams also developed budgets that reflected the funding needed to finance their care models. Reflecting this emphasis on staffing, we see that the majority of funding was allocated to personnel costs, followed by enabling technology and community partnerships. So now we're going to shift gears a little bit to talk about how we evaluated the impact. I think before we dive in, I just want to note that the chart funds are awarded to 27 hospitals, but some of the hospitals participated as part of a joint award, while others implemented more than one program at their hospital. So ultimately, there are 29 chart programs that were implemented and included in this evaluation, and that the evaluation was conducted at a cohort level. So what you see on this slide on the left are the 4 goals of Chart Phase 2, which capture transformation and care delivery both at the community hospital and at the patient level. And to measure progress towards achieving these goals, the HPC tracked chart team performance across 6 outcome domains on the right, which include operational use of data, provision of integrated whole person care, partnerships, acute care utilization, patient experience, and sustainable organizational change. Within each domain, we developed performance criteria and assessed each program. This slide might look familiar to those of you who are on CDT and attended our September meeting. To understand hospital transformation, each chart program was assessed based on their use of these 4 criteria: operational data, integration of whole person care, establishment or deepening of partnerships, and reduction of utilization for their eligible target population. The dark blue part of the bars represents the number of programs that met the indicators fully. The light blue represents the number that met the indicators partially, and the orange are hospitals that did not meet the indicators. But across all 4 domains, we see that the majority of programs made notable progress. So most of our evaluation was conducted at a cohort level, but we also did break down to see how performance varied based on whether programs were located in the emergency department or whether they had a focus on inpatient readmissions. And one notable accomplishment was that all of the ED focused teams reported reductions in utilization, with 9 reporting a 15% or greater reduction for their eligible target population. In contrast, we saw that inpatient-focused programs reported more mixed results, although it's worth noting that for those programs that didn't report reductions for their eligible target population, many reported reductions for smaller subgroups such as patients served or patients with a specific criteria. Consistent with hospital-reported data, analysis of CHIA discharge data showed that while ED revisit rates fell for eligible target populations at CHART and control hospitals, the decrease was larger at CHART hospitals than control hospitals. In the graph on the left, you'll see the ED revisit rate among patients with a behavioral health diagnosis. The CHART hospitals in blue fell more than the control hospitals in red. Again, focused CHART hospitals were more similar to control hospitals among eligible patient populations. Including patient voice was an important part of this evaluation. The Boston University School of Public Health team interviewed over 50 CHART patients to learn more about their experience in the program. When patients described the types of interaction they've often had with healthcare, they mentioned experiencing stigma, having multiple providers who were not all on the same page, feeling confused, and that healthcare is something that happened to them. When we asked about their experience in the CHART program, what they consistently valued most was the relationship-based approach. They appreciated having a caring person who reached out to them and made themselves available, which affirmed the emphasis on community health workers and other patient-facing staff who would connect with patients in their home or communities. Patients also described that CHART teams had changed the way that they interacted with their health care. Patients felt more confident and knowledgeable, actively engaged in their own care, and they appreciated more communication among their multiple providers. They also reported that they felt less reliant on the hospital, particularly the emergency department, to access the care that they needed. And finally, we turned our attention to our last impact domain, sustainability. So our analysis here drew on interviews with CHART hospital leadership, project managers, staff members, and community-based organizations that were partnering with the CHART programs, as well as strategic planning documents submitted by the hospitals to the Health Policy Commission at the close of their program. Many hospitals described how CHART catalyzed or contributed to organizational culture change. 4 key themes that emerged were: 1, the adoption of a more holistic approach to population health management, the recognition of the value of extending care beyond the hospital, embracing non-clinical staff as part of the care team, and an orientation towards data-driven decision-making. In general, staff and leadership expressed support for the CHART model and felt that the programs enabled them to provide patients with the support that they needed. They also reported a number of efficiencies realized during the operation of the CHART program, which lessened administrative burdens for staff managing the care of patients with complex needs. Overall, 23 of the programs were sustained in part or in total, and hospitals commonly cited organizational strategy and financial resources as key factors that influenced their decision-making around whether to sustain the CHART programs. Many also cited improved patient experience as an important motivating factor. Among hospitals that sustained all or part of their CHART programs, the majority cited their existing or anticipated participation in ACOs, particularly Mass Health ACOs, as a key factor that influenced their decision to continue their CHART roles and activities. As we can see in this quote, hospitals envisioned CHART as a pilot to prepare for oncoming changes in payment models. For CHART hospitals that participated or planned to participate in ACOs, CHART staff was often transitioned to the same or very similar roles, funded by the ACO, to support ACO's care management operations. Still, many community hospital leaders expressed concerns about their financial viability in an ACO arrangement and their ability to take on risk. Despite these concerns, most hospital leaders were eager to sustain and spread the chart care models and advocated for their adoption at the ACO level. The fact that 23 programs were sustained in part or total suggests that hospitals saw long-term value in the chart program and that building upon these efforts would be critical for their future success and position them to effectively manage utilization in a changing payment environment. So as we wrap up today, I really like this slide because I think that it captures the magnitude of change that the chart phase 2 was undertaking. Each of the goals of phase 2 was designed to transform traditional hospital care for both patients and how the community hospitals operated. Our evaluation found that the chart program enabled participating community hospitals to introduce new operational procedures and team-based care models that reached further into the community to deliver whole person care. And patients confirmed that the relationship-based approach of chart aligned with their own priorities. Most chart hospitals reported reduced acute care utilization for their eligible target populations. At the close of chart phase 2, hospitals expressed confidence that the chart programs had improved care and that the capabilities built during chart have helped position the hospitals to participate in value-based care. And lastly, chart hospitals enhanced their use of health information technology and learned new ways of tracking and analyzing data that can be used for programmatic decision making. I'd like to end with this slide here, which just shows all of the chart-related closeout documents that we are creating. We've talked today about the chart evaluation, but there are a couple of other things. The chart impact brief was presented at the September board meeting, which provides a high-level overview of the program's goals and key data highlights. And then there are two additional outputs here that we are also working on currently, wrapping up. The chart playbook is a practical guide that includes resources developed and used by chart awardees and key lessons that informed program design and implementation. And then the chart profiles highlight the specifics of each hospital's focus area, care model, and data highlights. Thank you.
Great. Thank you, Fran.
Thank you, Fran.
As the lowly economist, can I ask a question?
Mm-hmm.
So I understand all the benefits for patients, which I love. Did BU, or do you have any sense, did the program save the Commonwealth money on that? Like if you took the reduced utilization and so on, and you compared it to what it spent, like did it only improve health or did it also save money?
I think we didn't look at that question specifically, and this question also often comes up in the context of the individual hospitals. And the reality is, it's an ROI at an individual hospital level is such a unique calculation that we leave it to the hospitals to make that assessment, which is why we looked at broader factors around sustainability.
Yeah, go ahead.
I would just add too that I think David's point earlier about many of these hospitals used this funding. They were coming from a position of not having a lot of funding to be able to invest in infrastructure. Data and technology was a major obstacle that many of these programs tackled during the course of their performance period. And so I think when we think about the value of this program, I would, caution a little bit about thinking about it in terms of save money, because for many of these community hospitals, they were building infrastructure that sets them up for success in a future payment environment. Of course, I think there's always interest in thinking about exactly what you're asking about it in terms of impact on utilization as well.
I think it's a question that we definitely ran down as far as we could and worked a lot with BU to try to answer. I think this is one of those areas where in some of our further investment programs that we've been able to collect the type of data and information that can better be able to pinpoint that exact question. That being said, we did see reductions in acute care utilization. I think we estimate over 10,000 less ED visits as a result of some of these targeted programs. I do want to just ask Commissioner Blakely, you participated in a kind of a learning and dissemination conversation that we had a few weeks ago, and many of the chart hospitals were there, and I think they're still hungry and eager other systems are hungry and eager to learn about some of the activities here. And so I don't know if you had any reflections from that conversation that to share with the board.
Thank you for the opportunity, David. I think a couple of the messages I took away are what you just said, which is there's a lot of hunger to have space and funding to explore and to discover. And that's what innovation basically is. Innovation is messy, it's not linear. You don't always get the outcome that you want, but you often learn as much, if not more, from things that didn't go the way you anticipated than you do from things that do. And it's a challenge in structures that are so tightly funded and so tightly measured to be able to create the environment that allows for staff who have wonderful ideas, but no methodology and no framework with which to test those ideas, to be able to create models that put funding into the sharp point of care, where care is delivered, and invite the people who function there and are frustrated there to say what they think might work. And inevitably, what comes from that is not only some creative ideas that folks that work at much higher levels would never think of, but I think the lasting effect that comes from that is a group of people on the front lines who become energized and excited and want to try it again. And I think our challenge is to find ways through our mechanisms of creating those spaces that allow for that and encourage that. And then really encourage the facilities that have participated in these programs to learn from those lessons and to start to create an environment that encourages and that supports, to carve out those opportunities where people at the front end of care get to discover whether their thoughts and their assumptions and their I know what to do but I can't do it, be able to create that. That is the empowerment, an empowered staff with the support and the environment to be able to test those models. And so I think what we do here with these programs is to make it possible for institutions that struggle financially, who by that very nature don't get the opportunity to do it, to do exactly that. So I hope and look forward to multiple opportunities to continue to explore how we can open those gates. So I love it.
Of the 6 programs that were not continued, and one of your slides states that it wasn't because of ineffectiveness, right? So apparently they were affected to some degree. Did we dive into what the reasons were, and does that help us?
You know, we have a couple of hypotheses about what went on with the 6 who didn't sustain. The first is, as Fran mentioned, that with the arrival of the Mass Health ACO and other potentially duplicative programs, the work itself continued in some form or fashion, but possibly under a different name. The other thing, too, is that, you know, what CHART offered was an opportunity for all of these hospitals to get ahead of a market trend around value-based care. Our second hypothesis is that in some of these markets, the market did not move as quickly as we thought it might. So while they were prepared, they had not potentially achieved the level of risk that was sufficient that it made sense, to David's point, for them to continue to make investments in programs, particularly programs that would have the net effect of reducing utilization. So I think, you know, what we take away from this is, the good news is, to Barbara's point, the skills are there, the experience is there, the context is there for innovation. When the market does catch up with where we thought it would be, they will be in a better position than they would have been otherwise.
And I would just add, I think, you know, this is something that came out in the cost trend series too, is when you can move towards, you know, a true capitated or true kind of value-based model, it unlocks all of this innovation. And so, you know, I think to me, part of a lesson learned here is we have to keep pushing in kind of that value-based payment model, capitated models, because it unlocks the ability to use non-clinical staff in different ways, to partner in different ways. And when we're still on the fee-for-service hamster wheel, that is a barrier. I'm sorry, Chris.
How confident are you that the programs that showed reduction in admissions and ER utilization are going to continue to use data and analytics differently than they were 4 years ago? Are you mildly confident? Because we don't have any quantitative data for
You have a thought, I have a
Right.
thought. I mean, I would say I'm pretty confident, because I think once you've gone down that pathway and you start making decisions with a database as opposed to conjecture or qualitative data, I think it's very, very hard to go back. You know, I also think because some of them invested in information systems to generate those data, those things aren't going away. So I would be surprised if we saw a lot of retrenchment on that.
And I would just note, we've also continued to work with many of these hospitals in subsequent grant programs and have seen that they are much more capable of kind of jumping off on the next program, because they've built some of that kind of how to use data, how to identify patients, how do you engage patients. So I wouldn't say overwhelmingly confident, but I think there are some good indicators.
So in the, excuse me, in the phrase, sorry, some of that, there must be at least a few that they really gravitate toward as leading them to make better decisions. Even though the program doesn't continue, can we continue to ask them those questions?
Absolutely. I think there's a great opportunity to even, this is a cohort that we often convened and still have great contacts with. And so I think there's a great opportunity for us to check back in and to say, okay, even a simple survey could give us some insights on sustainability, even beyond when we asked about sustainability for the evaluation report. I think that's a great idea. I know we're out of time. I just also want to, we were doing a lot of thanks on chart, but I also want to thank Rick, who was the chair of the Community Hospital Investment and Consumer Involvement Committee, cheeky, and helped lead some of the committee work on this chart program over many years. Also, Wendy Everett was a key part of this program, so for the public.
David, you sound like a proud father sending their child off to college or wherever. So congratulations to everybody. This has been a phenomenal program. I am going to miss personally the presentations that the various chart hospitals have done before us of the progress they've made. And just, one observation I have is that very often, it picks up on Barbara's point, these were simple fixes, but they were constrained in their ability to see them as that and to implement. And I think the other piece here is the importance of collaborative care with community partners, because that is so important to changing what happens in the delivery of care. Our last item on unless there's anything else, our last item is just the schedule of the meetings coming up. I know the 2020 calendar has been published and is on the website. Our next board meeting is Monday, December 16th, and then the hearing on the pharmaceutical review regulations on December 13th. Am I missing anything?
Nope.
Good. With that, can I have a motion to adjourn? Yep. Great. I declare the meeting adjourned.